we could prepare today. It was different yesterday. It was different the day before, and it's probably going to be different tomorrow. And we really, I know from myself, I appreciate the opportunity to moderate the Aphasia Access session because as my esteemed colleagues understand, this pandemic has required our organization, the Triangle Aphasia Project, to shift and pivot and adapt to changes. We got together here about a month ago when we had our initial town hall meeting, and we discussed aphasia care in the midst of COVID. I think at that time we all thought, well, we could do this for a couple of weeks. And since then, I think we've all benefited from multiple webinars, trainings in our field and outside of our field, and let's face it, a lot of trial by fire. The lessons that we are learning almost daily are shaping our current situation and programming, but it's also shaping our plans for the future of service delivery to this population that we all are so passionate about. So, as well as significantly different geographic locations, which means different phases. North Carolina, for example, is in phase 2. I think people are talking about 2.5, not really sure if that's going to happen. And there's different hotspots. And inherently, we're also, since the inception of the Aphasia Access organization, we vary in our structures. And I often refer to this as the great trifecta, the Aphasia Access trifecta. We have programs that are based in universities. There's programs based in hospital systems, and there's programs that are independent, and even some aphasia groups that even just meet once in a while. Each of these are going to have their own regulatory, advisory, administrative makeup, as well as their own set of unique stakeholders. So today we have the privilege of input from these respected colleagues in each of these sectors, and I'm going to share my screen and set you up here with an introduction. For those of you who don't know, if your video panel is over Swathi and myself, you can put it right over me and push it down so you can see Swathi's pretty face. So we are anxious to hear from these amazing colleagues that we have, but we're also really wanting to hear from you. You are an important piece of the puzzle because we're all learning and we're all doing. And so this is going to be some, we organize the panel discussion to avoid redundancy of information. So each panelist is going to provide a slide representing their response to COVID, their current status, and their plan for reentry. Our objective here today is to review these perspectives and respect the overall goal to keep this vulnerable population safe, stimulated, and connected, and our service efforts sustainable beyond this global pandemic. So without further ado, I am so happy to be able to welcome and introduce, if you don't know, all the way from Ohio State University, Jennifer Brello. So Jennifer, can you share with our group about Ohio State University?
Absolutely. Thank you again for having me. As Maura said, I'm representing Ohio State University and OSU Aphasia Initiative, and we're a university-based group therapy program. And like most others, we jumped online pretty quickly, and now we kind of consolidated, and we're just offering one group per day versus 2 groups per day across the 3 days. But we were able to get probably 95% of our members, 95, online pretty quickly. We did some sidewalk like check-ins, delivered masks and things like that. We continue to offer our programs on Zoom. We're all virtual. We're doing some groups with occupational therapy now. But our plan right now, so we're still kind of waiting to hear more direction from the university, just because we have so many other people to take into consideration, primarily, students. We are the Aphasia Initiative, we're probably the last on the list to come back in person. So it looks like right now, I think if we get back in January, we'll be lucky. So that's kind of where we are. So I'll pass it over to Kitty, unless someone has questions. Is that what you want to do, Maura? Or
well, let's go through each of the everybody's, and then we do have some issues for discussion that we came up with, and also some questions to get us started, and ask for a little more further information on some of the stuff that you're doing.
Great.
So I'm really happy to introduce Kitty Binek, who is here from the Aphasia Center of West Texas, and she's going to present some information on what you're all doing down there. Go ahead, Kitty.
Well, we are an independent aphasia center, so we're a standalone organization. We are completely privately funded, so we don't take any government funds or insurance, and that's been in some ways really helpful because we don't have other people mandating what we have to do. We pretty quickly, like Jen said, we moved everything, all of our group programming to Zoom sessions. And that was a little challenging initially because some of our folks, they don't have people there who could assist them in maneuvering the technology. And, you know, so we had a few bumps in the road there. But one of the things that we did that I think was really helpful, we have a monthly family and friends group, and we moved that to a weekly offering. And so far, the family members are really taking advantage of that. We have maintained weekly phone contact. The program staff have done that with our members. And then we engaged our volunteers, just trying to keep them involved with the center, and we engage them to do letter writing campaigns to our members that are in assisted
Love that. That's great.
Facilities, as well as some of the staff did that as well. And currently, we recently, in fact, just this week, got our staff back to the office. Staff are now in the office full time. We had not been since kind of that last week in March. Staff had been working remotely, and then we kind of did a 2-week phase in of half, 50% staff at the office. And we're now, starting this week, we're back up 100% staff full time. And that's been really, really nice, actually. And a lot of our time now is really being consumed with our reentry plan. And I don't know if you want me, Maura, at this point to kind of get into some of the details of the reentry plan, or if you want to hit the pause button.
Yeah, we'll go on to what you're considering for your reentry, and then after Swathi does her 3, then we have some additional items for discussion that falls within, so far, everything you guys are talking about, so working well. So why don't you go ahead and talk a little bit about what your reentry plan is based on where you're located, and importantly, that you don't have, your stakeholders are different, and that you don't have some of the same mandates that other places do.
Well, and one of the things I think for me, just personally, that I just kind of wanted to touch on, because I think some folks may or may not find it helpful, but I know for me, as I just thought about reentry, and I think there's a lot of fear, and I know that I've had to work through some of my own fear, and I just challenge us all as leaders to think about our own fear level and just kind of working through that and thinking in terms of the people that we're serving and how much these people have already been through. And just to, I think if we lead with courage and we lead with strength and we can manage our own fear, I think it really will be helpful to the population that we're serving as we consider and think about opening our doors. And so that's challenged me, I know, just personally. But
I'll add to that just for a second, that one of the things we've been talking is kind of like a continuum of comfort, and we, for example, at TAP have a risk task force that we've implemented, and that includes a board member, a volunteer, staff, 2 family members, 2 different groups. And we asked, what's your comfort level in returning? And literally one said, well, as long as you clean and you clean up. And the other one said, when there's a vaccine. So, I mean, the continuum that we have to work with is ultimately the comfort of the individual. And I love the emphasis on leadership and demonstrating by example. So thank you for adding that, Kitty. I appreciate it.
Well, and I think, and I'm sure everybody's doing this, but I know one of the things that really helped me as well was just diving into our local statistics. And that really helped Beth Crawford, our program director, and myself as we talked about opening and looking at a date, was to look at, what really is the risk. And thankfully, at least here in Midland County, it's pretty low risk. We have 145,000 people in our county, and as of the 9th, 129 cases and 12 deaths. So, I think if our members can hear some of the statistical data, and that I think is going to help alleviate some of their fear, as well as just all the things that we're doing to try to make it safe for them to come back. And so as part of that, we are instituting some medical grade disinfecting equipment. We did some fundraising, and we got a Halosil fogger, which actually just arrived today. And we have a large multi-purpose room, which is where we will be putting people initially, because there's room to do social distancing. And we will be using that fogger to clean that room. And it's a fogger that they use to disinfect surgical rooms, surgery rooms. So it's a pretty high grade level of disinfecting. We also have ordered UV lights to disinfect smaller rooms, restrooms, conversation group rooms, our mobility van. When we first open, and again, our target date is July 7th, we're going to reduce our face-to-face programming to mornings only, at least for an initial 2 to 4 week period, as we kind of assess how things are going. And then in our afternoons, we will continue with Zoom groups. We're going to reduce the maximum number of member participants face-to-face to 6. And like I said, conduct all of our groups in that large multi-purpose room. And we'll have markers, just to help them know where to sit, and and that kind of thing. We are going to, at least right now, we're thinking we will require masks on the van, and then upon entry and exit. But during the conversation, we feel like masks would be quite prohibitive to that process. We're putting together no-touch hand sanitizing stations strategically placed in our building. Temperatures taken upon entry. We're working on a liability release that people will be required to sign. Our members will be required to sign. And individually packaged snacks at break. Only staff will be serving any beverages. We won't do any kind of lunch like we have typically done. Of course, any restroom assistance, any kind of physical assistance will be done with PPE. And then we're also looking at our current policies and procedures, and thinking about, that's even challenging as you think about modifying, are those going to be temporary modifications? Are those going to be permanent modifications? And how much do you want to hamstring yourself in a permanent situation for what we hope is a pretty temporary thing, although I guess none of us know at this point. And then we will be reviewing that plan, and staff and board have been involved in to varying degrees in putting this reentry plan together. So board and staff have all been part of the conversation.
That's great. I did your last comment about, you know, the policy and procedures. I said, I already developed TAP once. I don't really feel like redoing it all over again, but it really does feel like it. Everything that I'm hearing from some of these webinars and trainings is, you know, rewriting a lot of how things have been. So thank you for sharing that. I know we have more discussion topics on these specific things, including options for different types of PPE that will allow for a little more communicative access, like face shields and masks with the plastic and such. So we'll be talking about those. Let's join now Swathi Khan, who is here, Kiran, who is here from Boston. So Swathi, we're so glad you're here.
Yeah, I'm happy to be here.
Can you share what's going on?
So I think my perspective comes from three different but useful buckets of or themes. As the Associate Dean for Research, I'm having to help my college decide how the faculty are going to return to research. And some of them are working with Parkinson's patients, and some of them are working with kids with developmental disabilities. And of course, we're working with stroke and aphasic patients. So there's a lot of learning that we've done from that standpoint. As a faculty in the Speech and Hearing Sciences department, we're working and trying to figure out how students are going to get their clinical placements, because the Aphasia Resource Center is an excellent place for the students to get their clinical experience. And as a aphasia researcher, we are trying to figure out what to do with our patients, and our Aphasia Resource Center that Liz Hoover runs the programs for. So it's from three different perspectives, very complicated, but I think ultimately the response is quite similar to what everybody else has been talking about. We had to literally shut down everything within a few days during spring break. And at that point, all our research operations were halted, and the Aphasia Resource Center also all clinical operations were halted. Massachusetts, as everybody knows, was one of the second or third hardest hit states, and unfortunately for us, especially my lab, we work with a lot of Hispanic and underrepresented minorities, and the towns that we heavily recruit from were the ones that were really particularly hardest hit. So we did almost every aphasia patient involved in a retail study or the Aphasia Resource Center programs transition to group as much as possible. We have the added complication of having patients who cannot afford to have a computer or a Wi-Fi connection. So a lot of the transition in the months of March, April, May was about making sure that people who don't have access to technology have access to that. And that actually meant buying laptops and iPads and Wi-Fi hotspots for our patients and sending them and figuring out how to deliver them in a touchless, contactless way, which is all these things you never think you'll have to think about, but now you have to figure out how to deliver somebody a laptop.
Right.
So that's happening now. Because Massachusetts is in its second phase, I think we'll be reopening very slowly, although people are looking carefully at the spike rates. But Boston University is not going back to in-person for at least some time right now. Our physical therapy clinic is opening, and everybody's hoping to learn a lot of lessons from that. Only then we will think about opening up the Aphasia Resource Center and our speech and hearing clinic and my lab, because in the evaluation of risk to benefit, especially because we sit and look at young adults coming in for psychology experiments, and then old stroke individuals who have all sorts of high risk complications, including diabetes and cardiovascular. Most of our stroke patients are at the extreme of high risk, so they're not coming back anytime soon for in-person sessions. And they'll probably be the last group of people who'll be approved to come back. And in the meantime, though, I think we're learning a lot from our physical therapy clinics, where a lot of what Kitty described in terms of temperature checks and sanitizations and how to manage the restrooms and how to space them out, and will be actually implemented, and we'll try things out. So in terms of re-entry, everything that had been transitioned to Zoom will probably continue for some more time, because it seems to have been working fairly effectively once the technological kinks are worked out. We're going to continue clinical supervision through telepractice for the students to the extent we can. Of course, everybody wants to get to one-on-one therapy sessions, and I think there'll be some slow transition towards that, maybe by fall. But even fall, I think, is looking a little over-optimistic at this point, but that's the goal. I don't think we'll be doing group in-person for a bit. And then we have, the university is developing these procedures, these screening procedures, which essentially is a week before you set up the session, you screen them on the phone for a very exhaustive list of COVID symptoms. And then before you set them up for a visit, you have to screen them again. And then there are still questions about whether you would do temperature checks when they come in, because there's a lot of discussion about temperature checks being sort of too late to be asking them at that point.
Yes.
And then, the whole social distancing part, can we manage the tester, the clinician, and the patient in a way, who's going to help with the restroom, especially because our restrooms are shared by students and staff members as well. So there's added risk. So those are all issues that are being worked out. And I think for those reasons, we'll go very, very slow to bring people back.
Thank you so much, Swathi. We appreciate it. So we have a couple of issues for discussion, which we will pop up first. And then we have, and we know there are already some questions that are probably going to be asked. So I think we'll open it up after that point. But for the panel, I'm going to bring actually I'll stop the share and bring the panel back. For the panel, one of the things that you all talked about was the vulnerable situation that our clients particularly face, not only health, but communicatively. I know that this is a passion of mine right now, where we're finding out that people are not really having access to communication supports within the hospital. They don't have visitors. There's even a lawsuit that has been kind of just hit the news like yesterday about that. Can any of you speak to how vulnerability in both health and communication is being addressed by your organization?
I can start with that response, because I brought it up with our, so we, a large part of our population is, economically disadvantaged, and also, as I said, racially and disadvantaged as well. It has been, unfortunately, none of it has been a priori planned or strategically operated. It's all been reactive, and for that, I'm very, I'm quite frustrated and disappointed that we've had to do so much reaction. And I think, frankly, in the long run, I think it'll teach us some important lessons to make sure access to care is equitable for everybody. It's only at times like this that we've realized that our patients who are living in well-to-do neighborhoods with 3 computers and a Wi-Fi connection are, they're the ones that are most ready to start online sessions. And for them, the transition has been swift. And for the others, honestly, it's taken about 8 contacts to figure out how to get them a laptop, and then they don't know how to turn it on, and then to figure out how to set up the Wi-Fi spot. So we take it back, we set it up, we show them how to use it, but they're living in neighborhoods where it's not safe for anybody to go and congregate anywhere to show them. So those sort of lessons, I think, will teach us in the long run how to make access equitable for everybody. But for now, it's been mostly reactive, which is unfortunate.
That was really well put, and I think very timely, based on some of the urgent issues we're seeing and should have been seeing for a long time in terms of equity. So there's a lot of organizations sending information out, and I wonder how you guys are managing to decide which things. So I know already I haven't seen all the questions, but the checklists and the screenings and all of these things, there are risk management data and recommendations from and get this, more acronyms than speech pathology has: CDC, OSHA, FDA, EPA, DHHS, ASHA, the AHA. And I know in North Carolina, we're required to take, well, not required, but strongly encouraged to take a training that's statewide called Count on Me NC. And it is particular for cleaning. But then you go to another webinar or another training, and they start to talk about the level of disinfectant, and that people that have already health conditions, this is just an example, but people that are having asthma, and then we're throwing all these like harsh chemicals in the environment. I mean, it's very challenging, I think, for all of us to decide which one of these multiple organizations are providing the information that fits and aligns best with our organization. So any comments on that?
You know, we're trying to take guidance from the medical center because, you know, we are associated with an academic medical center. But
right.
I feel like for us, you know, in every meeting I'm in, it's like everyone's overwhelmed and no one knows what to do. And that's the end of it, you know.
Well, even the medical centers, my husband works at Duke, and he came home yesterday and he said they changed the temperature. So last week it was 99.4. And if it was anything above that, you were sent home. Now it's 100.4. So, or backwards, I'm sorry, it was 100.4. Now it's 99.4. Any other comments on some of these like compliance issues or risk management recommendations?
That has honestly been one of the things that has challenged me the most and been one of the most frustrating, is that it seems like every expert has something different to say, and then the goalpost keeps moving.
So no wonder we're being reactive, right, Swathi?
Yes. So it's do this today, do this tomorrow, don't do that. That's bad. You know, I mean, it's just, and I know that's really challenged me, and it has contributed to a level of fear in thinking about how do we really do this? Do we really open up when the so-called experts all have something different to say about it, and their opinions change by the day, seemingly. And I think that's been the biggest challenge really in trying to make the decision. And that's why for me, it was kind of, okay, I'm going to look at our county. I'm going to look at the statistics for our county, and along with staff and board, let's just really weigh, you know, this is life participation, and health encompasses so much more than just physical health.
Right.
It's mental health, it's emotional health, it's social health, and you know, that's challenging. You don't want to get tunnel vision, yet physical health is also very, very essential. So balancing all of this, boy, it has challenged, I know, me and our board and staff in a way that I don't think we've ever been challenged before, quite honestly.
No, Kitty, that is such an important point. And, you know, something that happened to us recently, you know, I've been so laser focused on the members, and I had a caregiver call me, and we were talking, and she said, I just want to run away. I'm not doing well. And then I thought, oh my gosh, I'm ignoring the care partners. And, you know, so we actually tomorrow we're hosting a support session. We're calling it caregiving during COVID. And we surveyed care partners so they can anonymously say what's going on right now that's new. And so we have a rehab psychologist that's going to kind of work through some strategies for them. So they can have like a private, just a session for themselves, just to try to give them something when there's not a real solution until, you know, there's some place for their loved ones to go, you know, so they each have their time, you know.
So I know that we'll be talking about some of the benefits that have come out of this, because you got to look on for the silver lining, right? For us, one of them was that reaching out to those support groups and caregivers. So our caregivers, both in the PPA population and in our stroke and brain injury, were rarely coming to support groups. They were not, attendance was very poor. People couldn't leave at the end of a day and come here after a full day of work and caring. Our response rate in terms of participation in support groups, we are never going to end support groups via Zoom. It's amazing how much more connection we're getting. So I appreciate that. And to your comments about all these different regulatory components, Kitty, one of the things I've been doing is in knowing I was going to be doing this, collecting a bunch of the websites. And I have put together a resource list that I was going to send out to Todd, and he could look at it and decide, if the board felt it was a good fit to put up on something. I'm happy to share it. I have been getting the most out of other organizations, people outside of our profession. So one I went to was attorney and a human resource person. I went to one for a doctor's office. That one really had some great information. So maybe kind of looking outside of our own discipline when we look at that. To that next point, and there's just two more before we kind of open it up to some of these great questions, is what about employment and volunteers and liability? And we're getting a lot of information about state and federal employment compliance. Can you make somebody come back to work? Is somebody, we were one of the organizations that applied for, and thank God, got the PPP for the 8-week opportunity. But now when we're looking at employees, if somebody says, I don't want to come, they're all contract employees here at TAP, so it's not going to be an issue. But our volunteers, I know you were saying you're working on liability, are you signing away? You guys didn't do anything wrong. I made this choice to be here myself. So did anyone want to talk to that?
Well, I do think liability is, again, it's one of those things that it really is challenging our organization right now as we think about volunteers and members and just visitors. We've got a sign-in log so that we have a log of everybody that's been in the building. So if, it turns up, God forbid, somebody has COVID, we at least know who was in the building, what dates, what time, and all of that, of course, goes to the liability question. But again, unfortunately in our society, anybody can sue anybody for anything. And so we have, like everybody else, we have an attorney on our board who will look at that liability release for us, but you never really know how good your liability release is until it gets challenged in court and nobody wants it to get there, right?
Right.
But yes.
So I think that
liability is a big issue.
The focus seems to be on both environmental modifications and procedural modifications. So environmental being capacity and signage and those things that you all talked about. And then procedural modifications get a little stickier with health screenings, logs. Here, there's some controversy on if you can do contract tracing, but that it's legally, because it's a pandemic, has to be reported. And then you get into, do you put the person's name if they have a temperature? And then how do you make those contacts? And then of course, cleaning and disinfecting and PPE and stuff. So it sounds like those are being answered by some of these resources, but if you have any final comment on those, we have one more issue and then we'll move on. So the last one, and this is really, I have to say, kind of came out of a personal and organizational standpoint, because like Kitty, our organization is entirely funded by donors, and we do have some grants. And during this time, one thing that has been very helpful is getting those grants unrestricted, contacting the donors and asking them to rethink that decision about restricting it. And that's really helped us with some of the additions that we didn't know we would have to do in terms of IT and that such. But we have been offering all our groups for free. Our group leaders have been volunteering, which, you know, we used to pay them contract rate. The big question is now, how do we monetize moving forward, especially when, for example, our organization is going to do some home, and then when we eventually go, you know, some Zoom, and then eventually when we come back, you know, what are some ideas for monetizing something that is going to have to be monetized to be fair too? That's a hot topic. Go. Anyone?
Well, I've been thinking a great deal about this because we stopped charging for our services at the point that we closed our doors and switched everything to Zoom. We stopped charging, so we have not charged anything since February, since that month. And in my mind, what I'm thinking is probably fair if they can come and participate here in the mornings, that we will probably, we haven't made the decision yet, but I'm thinking we'll probably go to half price when we initially open up, and then we won't ramp back up to our full prices, which are still incredibly low.
Right.
And we won't, yeah, they're very low, but we won't bump up to that until we're, you know, back up and running. And because again, this has impacted everybody's financial health as well. It's not just our financial health at the center, it's the members' financial health, it's their families, it's
exactly
our donors' financial health has been impacted, and all adds to the challenge.
Yes, absolutely. Anyone else on that tricky little subject?
Actually, I don't have an answer at all, and thankfully I don't have to think about the financial piece at BU, but I am curious to get other people's opinions about how they would ramp up financially in the fall. I think that's a very important question, and you know, the optimist in me thinks that there must be some learnings from the silver linings here. You know, you talked about caregiver mental health and such kinds of things that people will be willing to pay for as part of the package that they're getting, as you know, that the center is giving them. It's not just conversational therapy for the patient, it's support for the family member as well. And I would, like I said, the optimist in me thinks that, you know, there's value here. Just because you went to Zoom doesn't mean you have to give everything away for free. But I'm curious to see what other people are thinking about as well.
Absolutely. Well, let's see what people are thinking about here. I warned you that I'm going to be squinting and looking really close. So I'm going to go to the Q&A first, and then I'll move over to the chat. One of the questions in the Q&A was, would love to hear from presenters and others, where are you purchasing your safety equipment, foggers, thermometers, etc.? Amazon Smile and choose tap. No, I'm just kidding. Go ahead, Kitty.
Well, we purchased our HaloSeal fogger from HaloSeal. I don't even know if I'm saying it right, but it's HaloSil. If somebody wants to look that up, and they were great customer service. Answered all of our questions. I kept them on the phone for quite a while, and I think Beth kept them on the phone for a while as well, and they were just great. And then Room Scan, it's Room Scan UV Plus is the light. That's the company where we're purchasing the UV lights from. But we've had a really hard time just in terms of, you know, finding hand sanitizer and masks and gowns, and you know, it's
the UV lights seem to be really getting a lot of attention now. The wands, and
and these are they come on a tripod.
Okay.
And you can buy larger tripods. They come with small ones, and you put them in the room, you leave the room, they're remote controlled, and they, turn and just disinfect the entire area.
Fine UV light.
They're just turning around.
So we all need some extra sunscreen is what you're saying when we go to work.
Yeah, and so we'll be working we have someone that cleans our building, and we'll be working with her on utilizing those lights, but put them on rollers, and she can just roll them around after she leaves the restroom and let them do their thing for 15 minutes and go to the next one.
Okay. There is some questions about funding for these types of needs that we didn't anticipate. So not just funding for PPE and cleaning and disinfecting, but also where does the funding come for laptop, tablets, and Wi-Fi for your members?
I can answer that. So in terms of our research, it's been a big hole in our research expenses. It's just money we never budgeted for. And we've had to find ways to pay for it. For the clinic, I would, the college department is helping support some of that. But it's going to be, it has been for us. These are expenses that were never planned for. And it's not just laptops and Wi-Fi hotspots, which, I can, if anybody wants to look up those, I'm happy to help, find the right kinds of Wi-Fi hotspot plans and so forth. But it's also been masks and PPEs, and nobody, the kind of work we do, we don't have to plan for masks and gloves and fancy hand sanitizers, but all of that we have to now purchase and pay for, not just for the patients, for the staff that interact with them as well. So it's a huge financial hit at every level, top down.
I can tell you from a small nonprofit organization that there has been some really organic, amazing things happening with our group leaders. We also did, it wasn't called sidewalk things. We did more wellness calls and checked in on all of our clients and continue to do so. And when there was a particular client that was in need, kind of came back to the office, and then some of the group leaders just really embraced that and sent out messages on LinkedIn, and we got some people that had resources and actually that are going to end up being great connections for TAP that really probably aren't maybe donating things or donating money, but they don't know the real specific needs of nonprofits in their area. And so I think if we can find ways to reach out to the public in some ways, either through a newspaper article, if you can get an article written about how you're continuing services for people with aphasia, their news might be very interested in that, and then that's a good way to make an ask. Does anyone have, that was more internet question. Do the panels have, this is a big question, do the panelist members have students working with their clients? How has that worked with teletherapy and being at different sites? The state has allowed us to supervise students at different sites temporarily, and we don't know what the future will be. There has been, some people have said, what about supervision, and what about this whole idea of doing therapy? And we've crossed that bridge before. So any comments on the students?
Yeah, we've had students involved from the get-go. We typically, there's just actually myself and one other speech pathologist, that supervise in the Aphasia Initiative. And then, our workforce is graduate students and undergraduate student communication partners. And so we haven't been able to include the undergraduates as much, but the graduate students, we had kind of a little telehealth curriculum. They did some webinars and some things like that. And then we all kind of dove in together. And they spent a lot of time, a lot of the group sessions helping the members transition to using Zoom and maximizing Zoom. But everyone has actually adapted really well. I'm on the session with them, the whole time, obviously. And so we're going to, I think ASHA has allowed telesupervision through the end of 2020. So we're going to, stay as is. And I think it's a great skill, and I think it's wonderful exposure for the students. students embracing, discomfort and wanting to, willingly doing something new sometimes is a challenge. And so, but I am so impressed with how everyone's responded. So.
I have to second that. We were a little bit worried about transition, but in Zoom, actually, there's a clinical supervisor for one of our programs who tries to supervise multiple students. And they tried out the concurrent breakout rooms. So they would go into each of those breakout rooms and interact. It's actually worked out really well. And as you said, the fact that there's this provision now that ASHA is allowing the supervision to count more makes a big difference. And it's actually been quite easy of a transition because one thing about, at least in our case, because we work with adults, young and old, who have these neurological, strokes and traumatic brain injury, it's actually easier in some sense to get their attention when you're doing this remote video thing. Whereas if you're in a room with 4 or 5 people, you can't actually make out if they're all paying attention to you. So in some sense, the Zoom and group environment has worked out well as long as you have the video on. The other thing that came up as a discussion, and I never really thought about it, was that initially we thought we would try to get everybody to wear masks as soon as we could bring people in, because that would be the safe way. The interpersonal interaction was more important than trying to keep a tele interaction. But actually, what somebody pointed out to me was that when you're actually doing the tele interaction, you don't have to wear the mask, and the mask actually is a big barrier to feeling comfortable when you're interacting. So they prefer to continue this sort of conversation where I can see your face and I can see your facial expression. But if I was in a room, even though I wore the mask, I felt less connected because I now can see what people's expressions were. And so that was a learning for me, because I just took it for granted that everybody would want to be in the same room. So for those reasons, I think we will, try to keep the Zoom sessions a little longer, because it does, other than the fact that you're not in the same room, you're trying to mimic natural interaction as much as you can.
Yes, good. So there's one more kind of regulatory, and that is regarding HIPAA. And I know that everybody is concerned about people's privacy. Some of the things that I think Tom Sather had mentioned at first on the last call was about how people, we're taking a view into those people's homes. But at the same time, we're not only directly talking to them, other people might be behind them. We're not having those. So how are you all dealing with privacy issues? And if you're in the more medical component, the HIPAA? Nobody wants to touch that one with a 10-foot ball. Go.
We're just plugging away. There has been, talking about, unintended, positive, outcomes. We have been able to meet family members that we had not been able to interact with. One of our members has teenage children. And so the kids seeing what their dad is doing and what he can do has made a big difference, right? And so,
Jen, I completely agree. Again, one of the silver linings for us has been training people who didn't come to Learning to Speak Aphasia training, which we offer every month, but also reaching beyond that individual family. We're providing that training monthly now, besides just the queuing that you can support during the groups. We started offering Learning to Speak Aphasia monthly. And what we're seeing is that we're getting the kid who lives in Washington State and the kid who lives in New York City attending the Learning to Speak Aphasia. So they're better when they're communicating with theirs. That has definitely been a silver lining for us as well.
I can give you lots of what not to do's with HIPAA and just generally, patient confidentiality, privacy, because we've learned so many things. So we've been doing research online through video conferencing for almost 1.5 years, 2 years now. And it's really hard, even though we actually have a Zoom HIPAA account and we're all set up for that. There's still so many slips. Like even if you send the link to the patient with a you know, you save the file when you record the session. You have to be very careful about how you save the file. So there's just too many of these things that I'm happy to talk about for people offline. If they wanted to get ideas on how to start something, I can tell them what to be aware of.
I think that's great. That would be a really helpful resource. Maybe we can add, you know, some of the even examples. I know people have said, would you be willing to share this list or that list? There is a question, do you support Arabic language? I'm not sure who that's to, but it was to the panelists. And then Trish Hamburge was asking about clear face masks and face shields as PPA or PPE options. Too many PPEs, PPE options. The idea of the silver linings, the lessons, if there were something that you wish you knew in March when all this started, that you now know, what do you think would that be? And Jessica, if I didn't get to any of the questions, I've been kind of combining a couple that are the same. You can go ahead and reinforce those. Do you have any lessons or from other people? We're hearing a lot of questions, but are there people that want to share something that they wish they had known in March that they know now? Again, this is most important, is us sharing ideas and collaborating together. Feel free to put in the chat box if there's something that you learned that you would like to share with everybody.
I think a silver lining for us has been, this thrust us into the whole Zoom online chatting situation. And we had struggled with that before. And I feel like one of our big takeaways is that this, in some form or fashion, will stay a part of our programming, because it's helped us to connect to people who had moved to other parts of the state or moved to other states. And we've been able to bring those people back into the fold and re-engage with them. And it's just been exciting to have them be part of the conversation again. And we had staff meeting yesterday, and some of the staff were talking about one member in particular and just the energy that she brings to the conversation and the life. And she had not been able to participate face-to-face for several years, and having her as part of that again. And I think, just for me personally, one of the growth opportunities, I guess, really is that idea of facing your own, in leadership, facing your own stuff first and challenging myself to do that, right, so that hopefully I can, help the members and help the staff to have courage, to have strength, and to say, we are going to get through this, and we're going to take the positives that came from this, and it's going to make us better. But we're not going to hide, and we're not going to be afraid. We're going to do what we can. This is all about live participation.
And it makes me think, Kitty, by bringing that up, that it's all about everybody's comfort level. We've all gone outside of our comfort level. We've all learned to be uncomfortable and still survive it. I have to say, I think one of the other silver linings has been people being more confident or maybe experimental in trying other groups that they would not have attended. We have people coming to a book club that they hadn't been at before, or they're participating in other collaborations with other organizations. I know many of our clients now attend some of the ARC programs. There's something called Virtual Connections that ARC and the Aphasia Recovery Connection and Lingraphica has put together. And our clients we always say, please do this, do this. They really didn't get it until they started participating in our Zoom groups. And now some of them participate in this wider, world of aphasia. And I feel like the opportunities and as always, aphasia access folks, you all my professional colleagues, are so open to ideas for collaboration. And now our clients, you know, are interested in doing more of the writing to other members in different areas to learn more about, especially during June. And so I think those are kind of, we might be getting out of their comfort zone, but so are they. So it is.
I want to point out one quick thing that somebody
Yes.
brought up in the chat.
You have 1 minute.
Point. They said, make sure you have email addresses for all your clients, because otherwise you're left with a phone number, which I think is a very, very good point.
Absolutely. It's definitely shined up our databases, because we found out all of the mistakes that were on the database by trying to connect with people. So it is 2:59, and I want to, before Todd gets in and says his thank you, I want to thank each of you, Kitty and Swathi and Jen, for allowing me the honor of moderating this and participating with you. And on a bigger scale, my Aphasia Access family, I get so much from you, and without you, I'm really not sure I would have continued this for 17 years of TAP. So I feel blessed. I thank you guys, and I wish you health and ease in this transition as we re-enter the world.
Thank you, Maura. Thank you, Kitty. Thank you, Jen. Thank you, Swathi. Just a couple of notes. The video of this will be on the Aphasia Access website if all goes well with the editing tools tomorrow. We will also share it in next Tuesday and next Thursday's newsletter. So there'll be an easy point for you to forward that newsletter on to anybody who you think might enjoy and find value in here. For those who had resources, we will certainly make sure that Maura's list gets out. I'm happy to help distribute any list, any resource that you think will help the community. We're committed to getting out there. The trick to doing that is use the email address resources@aphasiaaccess.org. resources@aphasiaaccess.org. That goes into a high priority triage tool, or queue rather, here, so that it gets out quickly. It becomes our priority when somebody takes the time to share something that they think others can benefit from. Hopefully you'll join us next week as we continue our Aphasia Awareness Month festivities with a exciting panel moderated by Jamie Azos at Lamar that will have the 2020 recipients of the Tavistock Distinguished Scholar in the USA with us. Neat opportunity to look not only in research, but its connection to practice. So there will be a lot of practical things talked about and whatnot, and hope, especially if you're not familiar with the program, it's one of the things we here at Aphasia Access are so proud of that's come together in the last couple of years. Hope you'll join us for that. And the last piece is mark your calendars, especially for the kickoff on 11 a.m. on Wednesday, June 24th. But if you want to see a very frightening sight of Todd with no sleep, at 11 a.m. on June 25th, the day later, as we will attempt a truly global event, our 24-hour global teach-in. I'm thrilled to say that I think there's only 15 minutes left to sign up for. So we have a lineup that's going to span 24 hours, and you'll be able to watch it right at aphasiaaccess.org and a host of other places, but you'll be hearing a lot about that as we go. That's about it. We're just thrilled you spent a little bit of time with us on this Thursday, and hope all is going well where you are, and stay safe and all that. Take care.
Thank you.